Hi, my name is Isaac Blodgett, and I'm doing my psychology final presentation on post-traumatic stress disorder. I think it's an important condition to understand because of how many people are affected by it. And I think by learning about PTSD, we can better sympathize and understand where people are coming from. And I'm sure many people listening to this also know people who have PTSD, so hopefully that can be helpful. PTSD, as written in the DSM-5, is an anxiety disorder that develops due to physical injury or severe or emotional distress. And this is from some kind of inciting incident, which can be either combat, violent assault, natural disaster, or some other kind of life-threatening event. In 2024, it was determined that around 7% of people have PTSD in one form or another. And this kind of symptoms can vary, and it can be people re-experiencing their fear from that inciting event. It can cause anhedonic or dysphoric mood states, or arousal responses, fight or flight things where we are reacting to previous trauma, even if it's not currently present. To diagnose PTSD, there's actually several criteria you need to meet. And the first of that is exposure to threatened death, serious injury, or sexual violence in a few different ways. So this can be through experiencing those traumatic events, witnessing someone else go through a traumatic experience, learning of those things, or kind of repeated exposure to trauma. The symptoms you can expect with PTSD and the symptoms that we look for when we're diagnosing are recurrent, non-voluntary, and distressing memories of those events. It could be dreams, it could be flashbacks, or just generally reactions to the trauma or things that you want to look for. Avoidance is another key part of PTSD, and that is often related to conversations surrounding the traumatic event. It can be avoiding things that remind you of that, situations that remind you of your traumatic experience, or people, thoughts, feelings. Generally, people want to avoid talking about those things because that can bring an anxiety response. Mood alteration is another key diagnostic criteria of PTSD, and it is listed in the DSM-5 as negative alterations in cognitions and mood associated with these traumatic events, beginning or worsening after those events have occurred. And there's a list of a lot of qualities that you're supposed to have two of them for, and these can include inability to remember what exactly happened with your trauma. It can be kind of negative beliefs or expectations about yourself or the world, thinking things like, I am bad, I am not trustworthy, I can't trust other people, people are bad or dangerous. And this can also include kind of distorted thoughts about the traumatic events that you have gone through, either blaming yourself or blaming others. It can involve kind of persistent fear or guilt or shame related to those events. It can also include diminished interest in things that you normally like. The hobbies or activities that you are known to like, you may stop doing them. And a couple other things are detachment from others and an inability to experience positive emotions. Arousal is another diagnostic criteria of PTSD, and this can include irritable behavior, angry outbursts with little provocation, and this often manifests itself as anger towards other people. Reckless behavior, an exaggerated anxiety response, problems concentrating on things, and difficulty sleeping. And a couple final considerations are that when we're thinking about diagnosing PTSD, it's important that these symptoms are not acute and that they have occurred like over a period of time. And the way the DSM describes it is over 1 month. And that this disturbance causes clinically significant distress or impairment in occupational or other important areas of function, which basically means that it interferes with your day-to-day life and stops you from being able to function properly. And also that this disturbance cannot be attributed to substance use, because that's another diagnosis entirely. The history of PTSD is interesting because there were multiple attempts to try and classify what combat soldiers were experiencing post-war. And the veteran, feminist, and Holocaust survivor advocacy groups were important and in determining, including this in the DSM. Research about veterans from combat was important for creating PTSD as a diagnosis. And this is why a lot of the PTSD adjacent literature is specifically related to veterans. A few terms that PTSD used to be called or still get called sometimes, which I think is interesting, are acute mania, insanity, soldier's heart, irritable heart, shell shock, combat stress reaction, growth stress reaction, and dysphoria. Just thought that was a little interesting piece of history to add. And the first time a PTSD-like condition was noted in the DSM was in 1952, and it wasn't called PTSD, it was called growth stress reaction. What is an important difference between PTSD as we know it and growth stress reaction is that there was the assumption that these symptoms would go away quickly on their own and could happen to, I find it interesting how they included it as normal people within that. But an important change is that PTSD recently is no longer considered an anxiety disorder because it is often associated with other mood states like depression or anger, reckless behavior as well, which doesn't exactly classify it as anxiety related per se. And it's now included in the trauma and stressor related disorders. A few risk factors for developing PTSD are, like I said, combat exposure, a history of abuse, either physical or sexual, or some kind of accident, whether it be natural disaster or otherwise. People all ages can have PTSD, and there's a couple other diagnostic criteria if you are below the age of 6. And you are more likely to develop if you are physically injured during an event, have a job that exposes you to traumatic experiences regularly. Use drugs definitely increases your risk of that, or isolation also does. A few extra symptoms that I want to mention that were partially included in the diagnostic criteria, but I want to lay these out separately, are that PTSD symptoms include 4 major categories: intrusive memories, avoidance, negative changes in thinking and mood, and changes in physical and emotional reactions. So for those intrusive memories, this is often distressing memories of a traumatic event that come back and you relive those over again. For avoidance, people generally don't want to think or talk about their trauma or things that remind them of that. More symptoms related to mood are that you can feel detached from your family and friends, not remembering important aspects, or feeling that emotional numbness, you can't be emotionally stimulated in a way. And further changes in physical and emotional reactions are that you are easily startled, frightened, on guard, feeling like something bad is going to happen to you. And a few symptoms for children under the age of 6, which I think are interesting, are how you can play out that trauma. Like, I think play is often how kids like experiment real life situations, and for that kind of trauma, they feel like it's important to relive that through their play. Treatment for PTSD has a couple options. Cognitive behavioral therapy is a highly recommended option in that it focuses on the relationships between your thoughts, your feelings, and your behaviors, and hopefully trying to identify your current problems and symptoms and then change your thoughts accordingly to hopefully change your behaviors. And then prolonged exposure is another treatment option, in that gradually exposing yourself to trauma-related memories, feelings, and situations can be important. And supposedly by facing those memories, someone learns that trauma-related memories are not dangerous and do not have to be avoided. And then that wraps up my presentation. Thank you for tuning in. Here are my references. Thank you.